Welcome back to the Flex Diet Podcast. I'm your host, Dr. Mike T. Nelson. This is a little bit of the intro before the intro. And today I've got on the podcast Dr. Chris Morrissey. And we're talking about three kind of health procedure things that I think as a human being walking around, and especially as a trainer or a coach, you should know more about. And Dr. Chris is the person who has done some of these procedures. He's also working in fitness, so he is the perfect guy, in my opinion, to blend these two areas. One of them is going to be talking about the exciting topic of colonoscopies. And before you completely tune out of this episode right now, something he brings up that I was completely unaware of is you may even need a colonoscopy as young as 30 or 35 if you have certain conditions. So listen to this podcast. I think you'll find it useful and, again, could definitely extend your health, which is going to allow you to train more and just generally live a better life. If you're looking for things past exercise and nutrition and recovery to what is the next level of things you can do to extend your longevity based on science and be more robust, increase your recoverability, if recoverability is a word, check out the Physiologic Flexibility certification. Go to physiologicflexibility.com. If you're listening to this now in March, it will open again for 1 week starting around April 4th, 2022. So that would be your next opportunity to get in on the next enrollment. And if you're listening outside of that time, you can still go to physiologicflexibility.com, get on the wait list. We'll have lots of information there in the meantime, and you'll be the first to be notified once it opens again. In it, we focus on everything from cold therapy, hot, such as sauna, how to alter pH, which looks like some low-intensity interval work or some very high-intensity intervals. There's a specific way to do that. Breathing techniques, even things like fuel systems, ketones to glucose, and especially oxygen and CO2. Should you be doing specific breathing techniques both at rest, in sort of a meditation session, or during exercise? So nasal versus mouth breathing, etc. So go to physiologicflexibility.com for all of the information and enjoy this episode with Dr. Chris Morrissey. Hey, welcome back to the Flex Diet Podcast. I'm your host, Dr. Mike T. Nelson, and I'm here today with our special guest, Dr. Chris Morrissey. Say hello.
How you doing?
Good. I like your shirt for people who might not be watching us on video. What does it say?
It says, drink coffee, run hard, eat tacos.
Yeah, that sounds like metabolic flexibility to me, man.
That it is. I got it from, so I do the garage gym athlete training, and one of the guys does the merch for it, and his name's Trampus, and he has his own little company. It's called, I forget what it's called. But anyway, he's got a bunch of different t-shirts that we can buy through the website. So I bought some of those from him. So this was one of the ones. Yeah. So it's pretty cool.
That's awesome.
Yeah. I like it. So
very cool. And today we're talking about kind of three medical thingies, for lack of technical term, people should know about. And obviously this is not to be prescriptive in any way. There's no doctor-patient relationship. This is just, you're going to provide us with some cool research and things that if people are listening should take to their doctor, just kind of an outline of even preventative schedules. Like one of the items will be colonoscopy, which I've been avoiding, which I need to do. So maybe we can give people a kick in the butt of why they should do these things. Or if they have clients, I think it's also good because fitness professionals interact probably more with their clients than their physician does, for better or worse, to at least be like, hey, Bob, you're 65. You've never had a colonoscopy. You should talk to your doctor and go get one. And, hopefully just kind of prod them nicely a little bit more in that direction.
Sure.
Because even the amount of, I always blame it on guys because it's typically more guys than women, but the amount of guys who I work with who I'm like, hey man, when's the last time you had blood work? They're like, 5 years ago. I'm like,
right?
You should probably get that done.
Yeah, for sure.
Yeah. So give us a little bit of your background.
Sure. So like you said, my name's Dr Morrissey. I'm actually a general surgeon by training. I live down in Winfield, Kansas. I've been here since July of 2012, so almost 10 years now. I went to medical school in Kansas City it's changed names like 3 times, but it's the osteopathic medical school there. It's called KCU, Kansas City University. So I was there for actually 5 years. So the first 2 years of medical school is all in the classroom. And then the next 2 years are out on rotations, doing different, rotating through different specialties, internal medicine, family medicine, surgery, and all that. And I took a year off and did an undergraduate osteopathic manipulation fellowship. So in DO school, we all learn manipulation. So kind of the chiropractic stuff that makes DOs separate from MDs. So I took an extra year just getting extra training in that because I really liked it and it's helped a lot of people. So I did medical school for 5 years, and then we moved up to Grand Blanc, Michigan from Kansas. And I was there for 5 years doing my general surgical training. So we were about 10 minutes south of Flint and about an hour west of Detroit. So
fun place.
Yeah, I always said between the armpit and the butthole of Michigan, because
right.
Terrible towns. But anyway, so I trained there for 5 years, and I got this job right out of residency, and then came down here. Town's about 10,000 people, so there's me and one other general surgeon here, and I'm hospital employed, so I get paid the same whether I work or whether I don't. But I helped open our wound center, so I've been the wound center medical director since 2014. I also moonlight in the emergency room most Monday nights. So I'll work a 12-hour shift in there, just a doc in the box type of thing. I'm also the trauma medical director. We're a small, level 4 trauma center, which basically means that we stabilize and send people out if need be. And then I'm the medical director of our med spa here in town. So I do cosmetic and therapeutic Botox and filler and PRP injections and sclerotherapy. So I do a little bit of everything. But as far as general surgery goes, bread and butter stuff, I do gallbladder, appendix, bowel resections, a lot of colonoscopies, a lot of upper scopes, hernia repairs, just kind of whatever comes in, we, as long as we feel we can deal with it. And if it's not, we send it to a tertiary care facility, which is we have 2 level 1 trauma centers about an hour up the road in Wichita. So that's kind of what we do. But
nice. So you don't really do anything, just sit around on your hands all day and just
watch YouTube, and I don't do nothing at all. So yeah. But then last couple of years, I've gotten into, I'm also currently doing a functional medicine fellowship through the Institute of Functional Medicine online. So
nice.
I just kind of fell into this type of thing. And the main reason I was really attracted to it is because I'll have usually younger women that come in with nausea, vomiting, bloating, abdominal pain, and I'll work up their gallbladder. If it sounds like their gallbladder, I'll take it out. If it's not, I'll scope them. And then if it's nothing, then I send them on their way to somebody else. But then it's just I'm getting so many of these people, and I was like, there's got to be something I'm missing, something else that I can do. And so I've been learning way more about, the gut microbiome. And so I've been doing some modules. I hopefully be done my fellowship next year, so I can kind of institute that. And I kind of dabble in it now. I mean, there's a lot of that I don't know yet, but basically their pillars, which is something you kind of somewhat preach in your classes too, about sleep, nutrition, exercise, which is something that physicians learn zero about in medical school, at least the allopathic and osteopathic physicians. The naturopaths and the NDs or the chiropractors, they learn more about that than we do. But I'm just learning how everything is so intertwined, and that you can fix a lot of diseases just with good food and exercise, and so I've been doing that. And then I got personal training certification during COVID because I was bored. So I've got that and trying to get that up and going too. And, that's kind of about it. So I've just kind of really taken a turn to get into medical fitness, and I'm just trying to get in any avenue that I can to, maybe augment a side hustle and or help my regular patients if they're interested. So
yeah, that's awesome. I had this question on Instagram the other day too. I posted some stuff about longevity. Yeah. And one of the guys commented, which is a good comment. He's like, well, why did most physicians never talk about this? And it was, stuff like aerobic base, body, muscle mass, especially lower body strength, and then grip strength. And my comment was, and I'd love to get your comments, is that when I was doing my PhD at the University of Minnesota, like a lot of the anatomy and physiology classes we took were through the med school. So my minor was in anatomy and physiology. So we got to use their gross anatomy labs and stuff. So a lot of times we're hanging out with, I don't know, was it third year med students or second year or whatever.
Right.
And it was interesting just talking to them about like what they take. And, you could take your advanced, A&P, anatomy and physiology and et cetera. But a lot of it was like hardcore, like pharmacology.
Oh, yeah.
Like after that, I was like really shocked because I always ask physicians, I'm like, well, like how much training did you ever get on just nutrition and exercise? Not off on your own, because there's a lot of, docs like yourself who do a lot of that on their own, who are very well educated in it. And it's usually like an hour and a half, 2 hours. And I'm like, what? Like out of the entire med school, you get like a couple hours? And they're like, yeah, that's just, what diet, not to put the diabetic on when you put them in the hospital and, basic stuff. So we just don't kill someone and tell them to do the wrong thing, which I don't know. I just love your comments on that because it seems so backwards. And I know like physicians are in a hard spot because they get like 15 minutes per patient and like, bigger cities and stuff. So it's, right. They don't really have a lot of time to talk to them about, hey, Bob, you should think about exercise. But it just seems like it's very backwards.
Yeah, no, I'll echo exactly. That's pretty much spot on what we learned too. I don't remember exactly, the hours, but you could count it on one hand of that. I mean, it's just, we get so much crammed down our throats on, draw out the Krebs cycle, draw, all the, interleukin pathways and arachidonic acid cycles, all these like biochemical things that we have to learn, plus all the pharmacology. And so like, the way my school was set up is we had a systems-based approach. So
nice.
We did the first 6 weeks was kind of just like a hodgepodge of things that didn't really fit in anywhere, just kind of intro stuff. And then our second module was musculoskeletal. So we learned everything. So we learned all the anatomy and physiology of all the muscles in the body, and then pharmacology, biochemistry, so everything about that. Then we took a series of tests like anatomy practical, pathology practical, and then just different medications and stuff, pharmacology and histology. And then we would take tests and then we move on. The next one we did was like skin, blood, and lymph. So we had 2 weeks for like leukemia, lymphoma, all that, and then like 2 weeks of derm, and then 2 weeks of like blood dyscrasias and all these different disorders, which was a lot of information. And then we went on to cardiac and then respiratory and then GI. So that was our first year. Our second year was neurology, like all the neuroanatomy, which is like a 10-week course, which was a ton. And then we got into more like renal and then like endocrine, OBGYN type stuff. So, but as far as all that goes, yeah, I would say we maybe had one basics on nutrition, and it wasn't even anything about, okay, how many kilocalories are in a, fat, carbs, alcohol, and protein. And that was pretty much it. We learned nothing about different diets. Exercise was just like, yeah, you should, get up, walk or run maybe 100, 150 minutes a week, but nothing on any type of training, nothing about. We did some functional assessments, but it was more osteopathic, like, finding tissue texture changes and then doing the manipulation, the cracking backs and necks and different modalities to alleviate pain, so that was probably the most functional like assessments that we got. And we did like range of motion stuff and joint testing of all the ligaments and tendons and stuff like that. But we got zero education on sleep. I learned so much from just reading Matt Walker's book, Why We Sleep. Tons of stuff that I didn't even know about that. I read that like 2 years ago. So yeah, we just get very little training, which is sad. If you look at it from the functional medicine hat, like we're really good at acute disease, strokes, heart attacks, surgery, whatever. But as far as preventative health, we kind of suck at unless we take special interest in it, just because we're not trained in it, which is, whether that's right or wrong, I don't know. I feel it is kind of wrong because most people will go to their family doc and be like, well, hey, what can I do? My shoulder hurts. I'm trying to do these CrossFit workouts. What can I do? It's like, well, quit working out for 6 weeks, is the standard answer. Or here's some, ibuprofen, Tylenol. They don't go, let's go to physical therapy. Or, hey, instead of doing snatches, let's work on, whatever. So give you a different course instead of just avoid what you're doing, and or just like, I don't deal with that, go talk to somebody else. So, and not all doctors are like that. I'm not trying to bash anyone by any means, but in the standard training, that's what we get, which really kind of sucks. So
if someone is like, most of this audience will be interested in preventative health, and obviously they're doing a lot of stuff on their own, but is there sort of one person or sort of one training you would recommend people go to if they want to do more for lack of a better umbrella term, preventive health? Because I agree, it seems in the US, most docs are just not trained in it. And
Right.
If I'm in a massive car accident, yes, take me to the best, ER center you can find. If I get hit on the head, then yeah, do whatever you need to do. And most of the time, the places are going to be pretty good at that. But it's like, I got some blood work that's kind of weird. They're like, the last in-person physical I had was a doctor who looked like he was like 10 years past retirement. Like he barely kind of made it into the room. And I'm asking him, I'm like, hey man, can I just do like a basic blood work? This is back when I worked for a medical device company. So it's long time ago. And
Right.
so I had insurance, and he's like, it's 1 PM. You're not fasted. I said, no, I didn't eat anything this morning because I knew I was coming in here. I wanted to have blood work done. He's like, are you sure you didn't eat? I'm like, yes, I'm sure I didn't eat this morning. And it took me, several minutes arguing with him. And finally he's like, okay. And I'm like, well, can you look at a vitamin D level too? Like 25 hydroxy? He's like, oh, you're fine. I'm like, I don't travel. I live in Minnesota. It's February. I think I might be low. And I know that
Right.
if you suspect that it's low, hell, my insurance will even pay for it. He's like, I don't know. And he like pokes on me a little bit. Yeah. What are you? You're not quite 40 yet. Wear your seatbelt. You're fine. I'm like, that's my physical.
Wow. Yeah.
And that's horrible. Most places are not quite that bad.
Right.
But if someone wants to go in for more preventative health, is there any place you would recommend or things they can do? I know it's like a super loaded question.
Oh, kind of. I mean, like, you'll just kind of have to seek out, I would always start with your family doc,
Yeah.
and then maybe word of mouth. Like if you go to a gym, it's like, hey, who you guys go see for whatever. Kind of a specialty is integrative medicine, which is sort of in the functional medicine side. It's kind of more of a global health, in theory, family practice is supposed to be kind of like that. But again, it's more of not quite as arbitrary as what you had done to you from that person. But usually it's just, history and physical, and they'll, check basic blood work, but they usually don't get out there and check other like vitamin levels and stuff like that. There's more things popping up now, like different companies that have like apps. There's one that I did, I think it's called Inside Tracker, which I've done that before just on my own. And the only pain in the ass is just going to get your blood work done by somebody else. But otherwise it's kind of cool. And they give you it seems to be good quality, like levels and tests or whatever. But I mean, it's kind of word of mouth or finding some sort of, functional medicine practitioner. If you can find one of those are kind of more of the type that you're inquiring about. Or the Medical Fitness Network, which I recently joined, which I didn't even know was a thing.
I didn't know that was a thing either. I've just heard rumblings about it.
Yeah, I actually heard about it in the ISSN podcast, and I reached out to this lady, and I'm actually starting to kind of do stuff with them. I haven't really done much yet, but I was really excited hearing about that because they have CMEs and they have all kinds of things. But you can look up practitioners in your area that do medical fitness, because actually I was interviewed on the Garage Gym Athlete podcast once, and they had asked, about, well, who can we go to? How can we find a doctor that's interested in things like you are? And I was like, I don't know if there is it's just word of mouth. I have no idea. But then I found out about the Medical Fitness Network, and I was like, this is probably a place to start. But yeah, I would always start locally with your family doc and then try to find, you can go on that route. I mean, as long as I'm not recommending you go off on your own and rogue do vitamin testing and just on your own, that's not good doctorly advice. But if you're fairly healthy and you've been examined by a physician and you're healthy, you just want to know more about your, deeper dive into nutrition and stuff like that, I would probably seek out either functional medicine practitioner or integrative medicine or, naturopathic physicians. They're NDs, not MDs, but they get like 400 hours in nutrition and things like that. They're considered like holistic medicine, which is sort of an umbrella term for vagueness. That's not, I don't know, the regular like allopathic physicians and osteopathic physicians, they kind of look at it as out there kind of things just because it's under the term holistic, but there's a lot of good practitioners that do that stuff. So that's probably what I would do. I've never personally sought out somebody like that. I just kind of do stuff on my own because I don't know, I'm a doctor. I can do what I want, but so I don't know. That's kind of a roundabout answer, but that's what I would say.
Yeah, no, that's super helpful because that's a question I get a lot. And my kind of go-to answer is initially just a little bit similar to you. I'm like, just, even with my own clients, it's like, okay, go to your doc. Here's the test, that you should recommend. If your doctor needs a shit ton of research on it, I can send you with a whole bunch of PDFs to give him or her to to read. Most of the time, they'll just look at it and go, okay, yeah, whatever, and then run it. Sometimes I'll even look at what their blood work is. I have another guy who's a MD PhD that looks over stuff too. Again, not trying to diagnose or prescribe anything, but to me, it's just an extra level of data and a snapshot to look and see what's going on. And then at least you can go back to their doc and be like, hey, next time you go in, like ask them. We had one person, like their red blood cell count was just super high, and I said it to my MD buddy who I have on retainer, and I'm like, I just sent him, I didn't tell him anything about it. I'm like, what do you think's up with this? He's like, is she a cyclist on EPO?
Right.
I'm like, no. And it turns out, long story short, she had massive sleep apnea. So she's getting so hypoxic at night.
Interesting.
That her red blood cell mass is going up because her body is like, oh shit, we don't have enough oxygen to get around.
Sure.
So let's try to fix this by, bumping up red blood cell mass to try to compensate and get oxygen to the tissue.
Wow.
Which is wild. I told her, I'm like, go back to your doc and ask, her about why this is high. And it just didn't do anything. So we ended up sending her for a sleep consult. They're like, oh yeah, massive sleep apnea. And then the ironic part of the whole story is that she ended up not needing my services anymore because she had to pay several $1,000s to have her jaw realigned in her teeth because her tongue is falling in the back of her mouth, and her whole kind of facial structure was kind of a disaster, causing her sleep apnea. But which is fine. She's a lot better now. But it's crazy to me when I think back on it. I'm like, I wonder what would have happened like if she wouldn't have just got a basic blood panel just to look at it, because it, as right, sleep apnea, if it's really bad, and hers was really bad, causes all sorts of other issues, just on your body in general too.
Oh, yeah, for sure. I've never heard of us, like, I don't deal with sleep apnea much, but as far as having to get your facial reconstruction just based on, I've never heard of that before. That must have been super bad if they had to do that, because usually you put them on a CPAP and, recommend diet and exercise, and usually you can do a lot of things with that, but that's crazy.
Yeah. I did a whole podcast with Zach Couples on this too. And I think CPAPs are awesome and they definitely work. So I'm in the process too. My wife has gone through this, is going through it now, of looking at facial and jaw structure, and if there's anything you can change with that, even as an adult. So the short version is, I had just a disastrous teeth when I was a kid. I had teeth that were crooked, like completely sideways behind each other. So the standard thing was, which I'm grateful I had, orthodontics, which was good. For 4.5 years, I had headgear, I had springs, I had rubber bands. But in essence, all they were doing was like rearranging the teeth on a structure that was already too small. So it's not as some of the new, which is actually an older approach, is to, can we open up the jaw, maybe the palate a little bit, or change some of the underlying structure so that your teeth actually will move to a place that's better. So we're creating more space, not just trying to rearrange your teeth on the same structure. So, And the catch with some of all that is that it can interfere with your airway. And so if your airway is super narrow, then you're going to have stress symptoms all the time.
Sure.
So another buddy of mine, he's been doing this. He's in Chicago. He treats kids who have ADHD. And he's basically an oral dentist. I'm like, what do you, the first time I talked to him like 6 years ago, I'm like, what the hell are you doing? This makes no sense to me. And he's like, well, it's this simple. He's like, the kids I see, their structure is so bad that their airway is being impacted. And when we image their airway, it's super small. And so their brain thinks they're not getting enough oxygen. So all the symptoms they present are basically ADHD. So they clinically have ADHD because they're just like stressed out little sympathetic squirrels running around all day. And he's like, once we change that structure, especially in kids that are much more plastic, we get their airway open. And he's like, so far, like almost all of them, their symptoms of ADHD go away. It was just their brain was not getting enough oxygen.
Wow, that's awesome.
And I'm like, whoa.
Yeah, that's insane.
Yeah. So different pathway down that.
Yeah.
It's one of those things where it's like the amount of learning just related to physiology in general is just never ending. It's just there. Yeah. So I always think that's a good info where people can go to get more information, which is great. And
absolutely.
So if you're listening, get your blood work. The other positive, I think, is it's becoming easier to do it online. I mean, I confess I've done all my blood work only online in the last few years. And because of COVID, for better or worse, I think that'll become a much more real thing, where telemedicine, you may not be limited to just someone in your area. Obviously, start with the normal doc you see, but there may be more options, and they're dramatically coming down in cost now too.
Right.
Because if people are listening and they're business owners, and my insurance doesn't cover anything other than major medical. So everything is out of pocket on top of it. So having cash options that come down if you don't have insurance or only have major medical, and you don't have to go into someone, I think we'll have more options in the future, which will make hopefully some of these things easier.
Absolutely.
So you had 3 items you wanted to talk about today. What's item number 1?
Yeah, well, we kind of already brought up colonoscopy, so yeah. I guess we can start with that. We can kind of spin this however you want. I can just talk about the procedure and kind of what we look for and a couple of things if that's what you'd like.
Just give us some rundown. So for people who are listening, they may not know much about it other than I probably should have one.
That's number 1 for sure. So I guess kind of go through my normal spiel that I give in the office and
perfect,
kind of go from there. So as far as colonoscopies go, the previous recommended age to get them was age 50 if you have no family history and if you're having no problems. Now they've actually lowered that to 45, and I'm not 100% sure if all insurances are on board with that yet. I know some of them are. So I'm starting to see a few younger people that are around that age group to come in and get one done. But if you have a family history, though, you should get one 10 years prior to the youngest relative that was diagnosed with colon cancer. So if your father was diagnosed at the age of 40, you need to start getting him at the age of 30. And or if you're having any problems, big red flags you would see is blood in your stool, obviously, bright red blood, abdominal pain, changes in your bowel habits, just something that's not right. Your stool is changing in caliber, if they go from normal size to, like pencils or, pellets or something like that. So there's actually a whole cascade of like diagnosis of stool. It's really weird. There's pictures and you can show people, what does yours look like? The
Bristol stool scale where you see the pictures of Mr. Pooh in the office.
The Bristol.
Fitness people love talking about that stuff.
Oh, I know. It's crazy. It's so funny. But anyway, so if someone comes to see me, most often it's for screening. They're not having any problems. So when from an insurance standpoint, if you're having no symptoms and you have no family history, typically they won't pay for one before the age of 45 or 50 now. But if you're, any type of changes, I'm usually a very conservative surgeon, but with scoping, I scope people more often than not. I've had a few people that I've found colorectal cancer younger than 30.
Whoa.
I had one guy that was a couple years ago that his only symptom was it was just harder to push stool out. He had never had bleeding, had no weight loss, night sweats, none of that, no family history. And I was like, okay, well, it's probably just diet or whatever. So I went in and scoped him, and about, the very top of the rectal vault, which is about 18 to 20 centimeters inside the colon, he had a circumferential mass almost near obstructing. And so I sent him to a colorectal specialist, and he ended up having metastatic disease. He had big balls of cancer in his liver, and so he had to have a bunch of stuff done.
Basically it had already spread, right?
Yeah, but he had no warning signs. I mean, he said this has been going on for about 6 months, and there's, unless it was a really, really aggressive cancer, that it's been going on for a while. He just had no idea it was happening. So that was super unfortunate. So whenever I think about those things, I'm always like, I'm going to scope sooner rather than later. But
sure.
But it's one of the best diagnostic and therapeutic tests that we have. So meaning you can go and you can find things, but you can also treat at the same time. It's, I kind of tell people it's about 3 hours out of your day. You show up an hour before the procedure. The procedure is blocked off for about an hour, but usually takes 15 to 20 minutes, depending on how much work you have to do when you're in there, as far as taking out polyps and whatever. And then they go to recovery for about an hour. Then they go home. At our hospital, we use propofol, which is the Michael Jackson juice. You just get some white stuff through the IV and fall completely asleep and have no idea what's going on. And you wake up and you feel rested and go home.
Propofol is pretty fast acting, if I remember correct. Don't they use that for cardio versions, I think, too, if people have AFib?
Yeah, they can. It's just to sedate them before they do either defibrillation or whatever. Yeah, or at some. Yeah, we use propofol for a lot of things. It's a great drug. And it's metabolized by the liver very quickly. So it goes
I don't think there's much respiratory issue with it either, is there?
There's some, because they give a concoction
in high doses. It can be, but
yeah, and some people that are big drinkers. They
'Cause
tend to
liver.
require a lot more propofol, so it takes way more to get him sleepy enough so we can do something. So, but yeah, it's painless. The worst part's the prep. So the day before, around noon or about 2 in the afternoon, actually, we have them take a whole bottle of Miralax, which is a tasteless white powder that you mix and just have a ton of diarrhea. I always tell them, if you come in full of it, so to speak, I can't do my job very well because you can miss so many things. So,
Yeah.
just
So
that's
just
the worst
magnesium
part.
citrate is what they use to kind of clean people out, or is it different?
No, it's polyethylene glycol. So that's
It's PEG.
yeah. So that's what we use. Yeah, and
That'll do it.
it used to be the Go Lightly, which you'd have to drink about a gallon of liquid mixed with them. People have a lot of throwing up and just bloating from so much volume. But now using
Got it.
Miralax, you only have to use about half the volume, and it works really well. So different
cool.
places use different things, and some big endoscopy centers, they've gone to what they call a split prep, where they'll do half the day before and then half the morning of, if you're having it later in the day. And we just only do it in the morning, so we don't do that. And I would say about every 100 colonoscopies, I might get one that the prep is just not very good. So most people do really well with it.
Yeah. And I think that's the problem that people are scared about, because those are all like the horror, like the friends I know who've had it, like the horror stories I've heard were them like, I had this like 2 gallons of this crap I had to drink and I felt horrible for this long. And I'm like, well, yeah, you kind of suck it up. But I think knowing that the prep isn't as bad as what it quote used to be is probably a good thing, and hopefully will be less of a deterrent for people, especially, all these stories get cycled from like 10 years ago too. It's one person had a bad experience and that's all you hear about.
Yeah. It's either the prep, or they have a friend that had a friend that had a friend that had a perforation from a colonoscopy and had to have surgery. And so it's always a risk, and we always talk about it. It's super duper rare, but it can happen. But it's a very safe procedure. So, we drift off to sleep. We scope the entire colon, always do a rectal exam. Like for men, we check prostate, looking for lesions or enlarged prostates, and then just scope the entire colon. So when we get over to the right side, you can either see the opening of the appendix, called the appendiceal orifice, or you see the terminal ileum. And then from there, you just back out and you're looking for polyps or diverticulosis or, colon cancers, different entities, depending on why we're doing it. And then the nice thing is that there's polyps that are, I don't know, anywhere between a pinhead and even up to maybe even a golf ball. We can take them out endoscopically. There's a couple different devices we use. If they're smaller, there's these little like pincher graspers, almost like a little pair of tweezers type of looking thing on a long wire that we can do. Or there's like a little, it's called a snare, but I just call it a wire lasso. Basically, you'll wrap it around the base of it, lop it off, and then suck it out through the scope. Yeah, exactly. So that's cool. We can also tattoo the lesions when we're in there. So if it's a big mass, or either if you're removing the entire thing or you're going to mark it later on for surgery, you just tattoo it with some India ink. You just inject it into the mucosa of the colon, and then it'll soak up through the mucosa out into the serosa, into the abdomen. And so from a surgical standpoint, if you go in robotically or laparoscopically, it's kind of an X marks the spot. So you know exactly where the lesion is, because sometimes you can't feel it,
So it'll show up on the skin then, is that correct?
Not on it on the colon itself, but it won't go clear through like on your abdominal wall. Your abdominal wall. So
just when you get inside, you know where it is, right?
Got
it.
So it's on the outside of your organs, and sometimes you find this little spray of ink kind of in the area, because it all matters how to set the surgery up. Because if you're doing a right colon, you set your port sites where you're going in one side, and if you're doing a left colon, you just kind of got to know where it is. So if you're getting someone to operate on that you didn't do the scope on, you don't really know where it is. You're taking the GI guy's word for it, or whoever. And so you got to kind of,
it's right there. No, it wasn't there at all.
Right. And the other thing too is, the scope is numbered. There's numbers on it every 10 centimeters. And so you can say, oh, is it, 30 centimeters, which should be in the sigmoid. But sometimes if you get a loop in the scope, it's basically, like pushing a rope. And so you might actually be way farther in or way farther out than you think. And so that really makes a difference. So, but anyway, once you're done, you go home, and then I'll go over the pathology results in the office. And, there's a couple different types of polyps, if you want me to go over those. The most common usually is what's called hyperplastic. So those are basically like a mole. They never turn to cancer. They can get bigger, they can bleed, but they never turn to cancer. Then there's the adenoma family. There's tubular adenomas, which is the most common of the adenomas. It's got like a 5 to 10% chance to turn to cancer, depending on what you read. And then there's the tubulobullous adenoma, which is about a 30% chance to turn to cancer, and then a villous adenoma, which is about 50%. So the more you go up on that scale, the higher the risk of turning to cancer. And then they look at it to see if they've had any cellular dysplasia, and they'll mark that on the pathology. So then okay, it is rapidly dividing. We should maybe do a short follow-up in like 6 months to make sure that it's gone, or talk about an elective resection if it's got some actual cancer cells in it. So, but it's a great test. Nobody wants to do it. Nobody's super excited to see me in the office for it.
I can imagine.
Yeah.
Hey, it's my colonoscopy today, doc. Woohoo!
Yeah. No one ever is excited for sure. But yeah, so you can see a lot of things on the scope, and sometimes we'll do it just for abdominal pain or diarrhea. You can go in and take some random biopsies. There's ulcerative colitis and Crohn's disease that people talk about. So you can get those diagnoses sometimes off colonoscopy. Ulcerative colitis is only in the colon, and it starts like in the rectal area and spreads proximally. So you'll always find it there. And the main difference between those two, and you could talk an hour on each of them, but basically Crohn's can be anywhere between your mouth and your anus, basically, because it can skip around, and sometimes it's harder to diagnose. Whereas ulcerative colitis, it's in the colon. It only stays in the colon. So you can usually figure that out by biopsies. So that's another reason you might get a colonoscopy. But as far as colon cancer itself, it's like the third leading cause of death in the United States. So it's really
wow, it's that high.
Yeah, it is. And in the last 30 years, looking at statistics, there's a higher incidence of it. But I kind of feel it's like, well, I think we're just better at finding it. So I think we're finding it more than we were before. I don't think it's necessarily worse, but if you look at it with tying to dietary stuff, which we can talk about in a second, obesity is a huge pandemic also. And so it might be as a result of that also. It's hard to say for sure. But as far as a couple studies that I'd found, I saw one study in the Journal of Physiology from back in February of 19 that did show that. So the study was small. I want to say it was like 20 people maybe that had colon cancer, but they had survived it and they had operated and all that stuff, but they still had some residual cells in their body with some sort of lab values. What they did is they showed that acute high intensity exercise, and they define that as 4 sets of 4 minutes, 85 to 90% of your max. They would do those bouts, and then they would recheck their serum levels. I want to say like 2 hours, 6 hours, and 24 hours after. And they had statistically significant decrease in the amount of cancer cells in your blood compared to the people that didn't exercise. So
interesting.
Not saying that CrossFit will cure colon cancer. That is not what I'm saying whatsoever, but there's some data that is showing that. And they also had an increase in interleukin 6, 8, and tumor necrosis factors. So it was kind of interesting. So in a nutshell, basically, if you're, healthy, you can maybe prevent some of these things as far as with just diet and exercise alone. Another study that I'd found in a cancer epidemiology from August of 2020 is basically reviewing mechanisms by which coffee can be protective against colorectal cancer and gastric cancers also. So I was excited about that. For whatever reason, it said decaffeinated appeared to be statistically significant better of downregulating cancer cells than caffeinated. Whether that's true or not, I don't know. But I personally drink coffee for caffeine, so I'll take my chances, I guess. I don't know. But anyway, those are just a couple different things. But yeah, I mean, there's different reasons why we develop polyps and or cancers. Some of it's genetics. You can't really get around it. There's been some talk about red meat.
That's one of the questions I was going to ask, because that always comes up. Like, I know acquaintances who are like, no, I stopped eating red meat because of cholesterol and colon cancer. And the little bit I poked around in that literature, I'm like, I don't know. I don't think there's a direct link, but what is your thoughts?
From what I know, I don't think there's a direct link. I think just in general that they're looking at Americans because it's mainly in America more than anywhere else, but just our lifestyle of being more sedentary and eating crappy food and not exercising. I think that plays a big role, but like the red meat thing, again, kind of usually the typical person, you have a big steak, you have a big, huge loaded baked potato with everything on it, and you're not, in a soda or beer or something. So you're not eating healthy anyway, usually. But I think that's what's a bigger thing. I've never seen any direct, like, yes, eating red meat equals colon cancer, but I think it just makes you more likely, but I don't think I can't say for sure either way. And same with cholesterol. Like, I personally, I have high cholesterol. I've had it for years and it's genetic, and I've tried different things. I went almost vegan for 1 year and it dropped like 5 points, and that pissed me off. I was like a full year. I was being super good, turkey bacon. I mean, I wasn't complete vegan, but I would just like everything healthy, and it did nothing. And so I was, well, screw it. If it's not going to help, I'm going to just eat what I want and then exercise more or whatever. So, but the one thing that did kind of derail a little bit for me, Paleo Diet lowered my cholesterol by like 40 points.
Oh, wow. That's a big difference.
Yeah. I'd read Rob Wolf's book, The Paleo Diet, basically, and kind of got his background. And I'd forgot the little mechanism from med school when they talk about excess cholesterol or excess carbs get converted to cholesterol. And so I was like, well, I'll give that a try. And so I did it for like 4 months, and it dropped me from like, God, mine was up into like the 240 range, my total, and it dropped me down to about 210. And I didn't follow my own rules. I was teaching my medical students that rotate with me. It's like always, lab values is one time in space. It doesn't matter. Snapshot. You got to see where it was. And so I didn't look at my previous ones. And so it's like, well, it's still high. I'm going to go on a statin because I'm going to be an adult. And then, so I went on that for like 6 months, and I had a bunch of the muscle pains and weird cramps and weird injuries from lifting and running. So I was like, told my doctor, I'm like, all right, I'm quitting this because this is not helping me. It's hurting me more than it is. So I haven't checked it since then, but I still try to eat relatively healthy. And if I would have just given it more time, that might've been better for me. I don't know. It's just one of those things, but
yeah, I think part of that is also insulin effect on cholesterol production. If I remember right, I might be inaccurate on that. So the HMG reductase pathway, I think insulin makes it worse. So your body ends up creating more cholesterol, which is why if you look at data from unhealthy metabolic people versus healthy metabolic people, it's like completely two different worlds, right? And almost all the data we have is from people that are kind of metabolic train wrecks where their glucose and insulin are unregulated. And if you're dumping a crap ton of carbs into that system, it's probably not going to go well. You're not exercising, versus someone who exercises a lot. Everything else is pretty good. Their cholesterol maybe trending a little bit high. I'm like, yeah, maybe play with a little bit lower carbs, do some stuff. I think it can be beneficial, but I think people over extrapolate from metabolic unhealthy people to recommendations for metabolically healthy people. And they're just two different pathologies or physiologies.
Oh, for sure. Yeah. And we just, sometimes our numbers that we get things from, not to derail again, but the whole BMI thing, I don't know if you've researched that much. And I just actually, I did my own podcast. That was my topic for this week, is the BMI and how it's pretty sucky, and kind of talked about its origins or whatever, but it's all, but we base everything off of that. And yes, I check it. I mean, it's just on my paper, but even me, I'm overweight because my BMI is like 27. I'm 5'8" and weigh 180, 185, just depending on the week or whatever. But it's just like, yes. Do I have a 6-pack? No. But am I overweight? No. But it's just not a good gauge of anything. So, And going back to the colon exam, what is do you know about what the risk is of a perforation? Because that's the prep and like the risk of perforations are probably like the two main objections I hear from people like almost all the time. So perforation, I want to say it's like the last numbers I think I was like 0.02% or something. So
pretty low, possible, but extremely rare.
Has it happened to me? Yes, it's happened a couple of times, but it's, both times it's happened, they'd had a bunch of previous operations and or they had other medical diseases that made things more friable than others. And, it's in the risks and we talk about it. And then if it happens, we go in and fix it. The worst part of it is if you miss it, you don't know that you do it. Cause sometimes at the time you don't know that it's evident. One of the times it happened to me is I had no idea. It was just a small, tiny hole. And they came back 24 hours later to the emergency room with nausea, vomiting, abdominal pain, fever. And then I got a CAT scan and they had what's called free air, basically where there's a little hole in the colon and a bunch of air in the abdominal wall or cavity. And so I'd go in and find the little hole and oversew it and it was fine. But sometimes we don't know that it happens. But yeah, it's like way less than 1%. And so it's super safe, probably, I don't know, statistically probably die in a car wreck before you get a colonoscopy perf, but it's just unfortunately with anything in surgery or medicine, there is risks and you just have to talk about them. And as long as you're upfront about it and, be honest and tell people about it, then if it happens, it's so super sucks, but you go in and fix it and, it's fine. So,
yeah. Cause I think people also have to be aware that there's a pretty high risk of having colon cancer. Right. So it's not
Absolutely.
like you're going in there for nothing.
Right. Yeah. And if you're going in and just doing it because you wanted it done, that's something. But if we're actually looking for disease, and then, you know, and then so if you end up having colon cancer and having to have chemo, radiation, and or colon surgery, then you're going and having an operation, part of your colon out, puts you at higher risk for getting, hernias later in life and or whatever. So it's like from a fitness exercise standpoint, it may limit you after having it just because some people have it repaired and they're completely fine. They can do whatever, but other people are plagued with, chronic pain and hernias and all that stuff. So to me, going in with no cuts, going in through the rectum, and if you can take care of things before it starts, it's way better than waiting too late. So for sure.
And is there a blood test now for colon cancer? I've heard some rumblings that there is, and some of the docs I talked to said yes, but it's not really that reliable, and there's sometimes false positives, and the colonoscopy is still kind of your gold standard. So
yeah,
if you're going to have a colonoscopy, why even bother with the blood test? But I don't know if you know anything on that.
As far as blood work, I don't know of any specific blood test, but there's the DNA sample that you can send in through the mail, the ColaGuard, it's advertised on TV. So it's better than just, because before we would just do what's called a fecal occult, where basically you take some stool, smear it on a card, and put this little developer on there. And if there's blood present, then it's positive. But it's non-specific. So you could have had a little hemorrhoid and had a hard bowel movement and been a positive for that, or gastric ulcer or gastritis that cause just enough bleeding to detect bleeding. But the ColaGuard is actually supposed to be better because it looks for actual DNA, but the false positive rate is like 15%. Some of their data seems
pretty
skewed.
high, if I remember right, when I just poked around a little bit.
Yeah. And so to me, I never recommend those. And it's not because I'm greedy and I want to do procedures. That's not it at all. It's like, I just don't think it's a good test, because if it's a false negative, that's not helpful.
Right.
If it's a false positive, it's not helpful. And so, right. And out of all the positive ColaGuards that I've seen, I think I've only found a polyp in one person, and they've all been completely normal otherwise. So I've never found colon cancer in someone with a positive ColaGuard, just in my experience alone. Yeah. That doesn't mean it doesn't happen, but I just don't think it's a good test. Just colonoscopy is by far the best, for sure.
Yeah, just I threw it out there because some people are like, oh, but I can get this other test and I don't have to do a colonoscopy. It's like, yeah. Yeah.
The only reason I would recommend it is if they have like way higher risk to benefit ratio, if they're, got horrible ejection fraction of their heart, or they're on blood thinners they can't go off of, or,
sure,
a lot of renal
procedural
problems.
Risk.
Yeah. So then I would say, okay, let's get this and follow it. But otherwise I just recommend a scope. So
yeah. Awesome.
Yeah.
What's number 2 on the list?
So number 2, we'll go on to gallbladder. That's probably one of the most common surgeries that I do. And again, we can kind of talk about whatever you want, function.
Yeah.
Diet.
What does a gallbladder do for people listening?
So gallbladder is a little pear-shaped organ that hangs out in the liver on the bottom side. Basically, it's a garage for bile. It's kind of how I explain it to people. So your liver
garage.
It is. It's a bile garage. So the liver makes bile, a bunch of it throughout the day. And so some of it gets stored in the gallbladder. And so the way the gallbladder is stimulated, so like in a normal natural sense, you eat a meal that's higher in fat, then your gallbladder, there's a signal called cholecystokinin, or CCK, that's released from your duodenum, and it goes up and says, hey, we need help breaking this food down. So then your gallbladder will squeeze, dump a bunch of bile down in there, and so help start emulsifying fat and breaking everything down so it can be absorbed for nutrients and whatnot. So that's the normal storage, or the normal function of that. Most people, they can get along fine, but some people, they have problems. So there's kind of 2 big reasons to get your gallbladder. Well, there's more than 2, but the 2 main ones I typically see is either you have gallstones that is formed from over the years of bad diet and maybe lack of exercise. There's some correlation between that, or if it just doesn't work properly. So, if I get a patient in the office that's, hey, I might have gallbladder disease, the first step we do is getting an ultrasound of the gallbladder. So go over to radiology, they put jelly on your belly and look around. And so from a general surgical standpoint, I look for 4 things. I like to see if there is stones there or not. I like to see how thick the gallbladder wall is, because a thicker gallbladder wall can indicate either chronic inflammation or acute inflammation or infection at the time of the scan. I also look to see how big the common bile duct is, which is the main bile duct that drains the liver. And then I look to see if there's what's called pericholecystic fluid, or fluid around the gallbladder. So basically it's just looking at anatomy. So if anything of that after doing a good history and physical exam, checking blood work. And if you have stones or it looks thickened or whatever, and your story fits with gallbladder disease, we'll talk about taking the gallbladder out. Sometimes though, you get in there and the ultrasound is completely normal. And then they're like, all right, what's next? And so depending on what I think it is, if I'm on the fence where it's like, man, this could be stomach or this could be gallbladder, I'll give the patient the option. I'm like, okay, these are our options. We could either go continue down the gallbladder tree and do a different test, which I'll talk about in a minute, or we can just go do what's called an EGD, which is an upper scope, where we can go down and just like a colonoscopy, but you're going down the throat into the stomach. And I'll go through that in a minute as well. Looking for gastritis or peptic ulcer disease or, duodenitis or something like that. So just because based off where all the embryologic origins of the gut, the foregut, they all come from the same area. So some of the pain distribution is the same. So sometimes it's really hard to figure out, like based off just story alone, what it is. Because sometimes it's a slam dunk. Sometimes it's like, I don't know, it could be flip a coin and pick.
Well, yeah, it's like abdominal pain. Okay. Right. I mean, I think people sometimes forget that where you have pain, especially in the visceral area, the abdominal area, the mid part of your body, whatever term you want to use, it can be sourced somewhere else.
Yeah.
It could be like, I've got pain in this lower area. It doesn't mean that there's something going on in that area specifically. There definitely could be, but it's not like, point here. Oh, that's the liver. Oh, there's the gallbladder.
Right. It'd be nice if it was that easy, but it's not always that easy. But yeah, so if we're going down the gallbladder tree, the next step I would get is what's called a HIDA scan, which is a gallbladder scintigraphy. So it's a nuclear medicine study, and it checks the function of your gallbladder. So your gallbladder might look completely normal, but it's just not working well. So you go over, it's a 2-part test. You get an IV, you get an injection of some dye that the dye will go up into the biliary tree and light up the gallbladder, light up the hepatic branches, and then just to see if everything fills up properly. And then there's a next step where they'll give you synthetic CCK, and then your gallbladder empties, and then they calculate your ejection fraction of velocity and how much comes out or whatever. And they calculate how well your gallbladder functions. So based off of that, we may go to the operating room and take your gallbladder out.
It's like a cardiac nuke scan, but for your gallbladder.
Exactly.
People are familiar with that.
Yeah.
Right. Yep. So you go in there, you light it up with a bunch of dye, and you see what happens.
That is how
I know
exactly
it's a dramatic oversimplification, but
well, no, I mean, that's pretty much what it is for sure. So, and what's weird is, the ejection fraction, what's considered normal is greater than 35%, which why they picked that number, I don't really know. That seems low. Like if you look at any other percentile, it's a low number. But so if it's less than 35%, that can be an indication as long as the story fits. And, because it can be, if you've been fasted for a few days and haven't been eating, if you've been sick or whatever from other entities, your gallbladder fraction can be lower just because your gallbladder is not as full and it's not functioning as well. So you just got to go with the whole story. So less than 35% and the other thing I always talk about is reproduction of symptoms. So if they're like, oh my God, it feels just like I did when I ended up in the ER, abdominal pain goes around to the right side into my back, like I feel that's a positive test. Let's go take out your gallbladder. If it's above 35%, that's considered normal. However, again, if it's 50% ejection fraction, which is completely normal, but it's exactly the way they felt, I don't really care what the number is. I take the gallbladder out if it's based off of that. And then in the last 3 years, there's been a new study showing that people that have hyper functioning gallbladders, so their ejection fraction is greater than 80%. Because before we always considered that as normal, but I'm actually in the camp of believing that if you have hyperkinesis, which is the word, even though it's a misnomer, but the gallbladder works. Movement. Yeah, the gallbladder works too fast or too hard or whatever. But I've taken people's gallbladders out for that. I think I have about at least 12 patients in my practice with that specific thing. And I would say all but one has gotten better. Like they're completely fine. So not all.
What's going on with that? Like what, do they present with the same symptoms then or different symptoms?
No, it's same symptoms. It just sounds like weird. Gallbladder, but then it's like, oh, well, your gallbladder function is completely normal. But then it's like, so 5 years ago, I'm like, well, it can't be your gallbladder. It's got to be something else. Go see GI or do something different. But now that I've learned, I read that paper was out of I think it was out of California. There was a general surgeon that had 25 to 30 patients that he believed that there was more to it. So he just took people's gallbladders out. And I want to say 90% of his patients all got better. So I kind of based my, practice off of that. And I've had really good luck with that if it's, obviously the right problem. Because I always say, I tell people if you come back to me thinking I'm a magician that you feel amazing, then we did the right surgery. But if you come back and you're like, I feel the same, it's like, crap, we chose the wrong thing.
Yeah.
So, yeah.
I think that some people should realize too, is that I think there's an assumption that physicians, even the best educated, most well-intentioned physicians, have all the data and that we understand everything. And that's like so far from the truth. It's like you're doing the best you can, always based on limited data, which means that you can follow all of the rules, all of the best data, do everything to a T, but it may not solve their issue, right? Because there's so many things that we just don't understand yet.
For sure. And I always tell my patients that I'm like, this should help you. I'm not going to promise you, I'm not giving you 100% guarantee you're going to feel amazing, because you should, but you might not. So as long as you're on board with that, we'll go ahead and proceed with your surgery and see what happens. So, so that's kind of how I practice. And there was this paper that came out, I don't know, 8 or 9 years ago that showed since laparoscopic surgery has been invented, like surgeons do too many gallbladders because it's drive-through surgery. You come in and go home the same day. And in general, right upper quadrant pain does not always equal gallbladder disease. And so sometimes we jump at the, some people are more eager to do procedures than others, as far as for whatever reason. And so I'm of the camp that I want to make sure that I'm doing it for the right reason, not just doing it because I can. So I kind of really make sure I want to do it for the right reasons before I take someone's gallbladder out.
Do you think that's a little bit of a carryover from, lack of a better word, old time physicians of just taking shit out? Like, your tonsils, don't need them. Appendix, take it out. Gallbladder, bah. I don't know. That's an oversimplification, I'm sure, but
there may be some truth to that. But I feel some of us that have trained more recently that were,
it's gotten a lot better.
It has. And, just doing it to do it isn't, again, always the right reason, but as long as we're going to help somebody out, but yeah, there's some people that just, I can do this procedure. I'm going to do it because I can, and medicine, there's been scams over the years with different things that you read about, different lawsuits for people doing unethical things. Unfortunately, it happens in our profession, but I like to think most people are out to help and not just, there's better ways to make money than doing it just to do it, So.
Yeah. And I think we learn more about what each thing is doing as a function. Right. Because I think, my guess is a gallbladder is probably doing more than just sequestering bile, even though that's its main job and that's what it does in life.
Right.
Like, we used to think the appendix, who needs an appendix? It's just an extra vestigial thing that's just hanging out there. It doesn't do anything.
Yep.
Now we're like, oh, yeah, it actually does some shit. Oh,
right. No, I mean, it does have a function. It's got a little bit of immune function, but, we always say God gave us an appendix for surgeons to have something to do. So yeah, that's kind of what we say. But yeah, I'm sure there's a lot more stuff to gallbladders than we know, but, obviously people can live without them because we do a lot of them every day. And, as far as complications of the procedure, most commonly you can have transient diarrhea, after every time you eat, you go to the bathroom, and that's just your body. Your liver hasn't figured out how to secrete more bile to help break down food, because normally it can rest when the gallbladder is present, because then the gallbladder kind of does its job. But now the liver's got to hey, I got to pump out more bile over the day to help break down food so you can be normal again. So that's kind of one of the things that can happen after gallbladder surgery, other than, bile duct injuries and other things that can happen. That's kind of the big complication, if you want to say, but it's pretty rare too. It almost always goes away within 3 to 6 months.
Yeah, I was going to ask, do you know how long that hangs out? Because that's one of the questions I had, is that, like, on intake forms, like if I find someone is super sensitive to high dietary fat, I'll ask them if they've had their gallbladder out. And sometimes it's like years later and they're like, yeah. And in my head, I'm like thinking, what is kind of the timeline? Because the body is going to adapt, and over time, it's probably going to figure this out. Mm-hmm. So is it just a coincidence that they're having a dietary issue with fat and their gallbladder came out and it's not a bile issue? Or because they're missing a gallbladder, is it potentially a thing, or who knows?
It's I don't think we completely know, but what I tell my patients is, on average, I say it can be 3 to 6 months. I know I have one person in my practice that just has chronic diarrhea every time they eat. They run to the bathroom, and there's nothing we can do. Now, whether it's other dietary things, I don't know. I haven't followed up with them for years, but in general, most people, they'll have 3 to 6 months of possible diarrhea. I've had a couple people though, they're like, oh my God, 2 days later, I went and had a foot-long chili cheese coney from Sonic and I feel amazing. It's like, well, most of the time we recommend a diet lower in fat, in the short term, just to make everything not work as hard and be easier on your system. And I always tell people too, it's like, if there are foods that wrecked you before your gallbladder, just avoid those for a while. And then after a month or so, just test it, just eat something, and you're not going to hurt anything. You'll just feel like crap if you're not ready to do that yet. But I would say 3 to 6 months is the general thing. So if it's 10 years later, it could just be still a chronic, what they call dumping syndrome after, gallbladder surgery, but it could be something else too. It could be their gut microbiome's wrecked, or their, some sort of other, trash can diagnosis, IBS type of thing or something. So it's hard to say. But
is there any supplements or anything that may help with that in the transition period, or do they just keep reducing fat and keep it kind of under sort of a threshold till their body adapts?
I haven't learned of any actual like natural supplements that I know of yet. People talk about bile salts, or whatever,
bile salts and ox bile, and there's some interesting things out there
for sure. And I've never prescribed those, and actually that's one things I'm learning about in the functional medicine thing. So I haven't got to that part yet, but I would kind of tell people low fat diet, things that bother you, avoid those. For whatever reason, lettuce is a big trigger, and I don't know why that is. It doesn't make sense, but people have came to me before that they're like, every time I eat salad, I'm like, well, what's on your salad? Usually it's eggs, bacon, fatty ranch, all the things that you dress salads up to make it taste good. But sometimes they're like, I just eat like a turkey burger with a little piece of lettuce and I am just wrecked. And so it's like, okay, well, so whatever. I don't know why lettuce is a trigger, but that's one that I've learned more often than not, that people say they eat lettuce, and it kind of makes me look at their gallbladder if they still have their gallbladder.
Interesting.
But yeah, it's weird. I don't know why that is. But yeah, a lot of times dietary things, like talk about gallstones, 80% of gallstones are made up of cholesterol. So typically people that have a higher cholesterol diet, or, that doesn't mean they have high cholesterol systemically, just their dietary intake of cholesterol, that it's more propensity to form gallstones. So the rest, like the less 15% of gallstones are like calcium based usually. So, but the majority of them are gallstones, and it's really weird. Everybody's different. Like I've taken people's gallbladders out. They have one huge one the size of an egg. Other people, it comes out is like sand. Some of them are pebbles. I took one guy's out that had like 100 little rocks in there. So it's just weird how different people make different things. And I don't know why that is for sure, but
yeah. We see that in the vascular system too, right? We used to always assume that it was all plaque, and now there's different types of plaque. There's vulnerable plaque. There's when I did a dissection once, we had a couple times just complete calcification of the vessel, and it was like a hard pipe. Yeah, it was just hard as a rock. You're like, whoa. And it's just so crazy to see differences in quote unquote the same organ, Oh yeah. I always find that just fascinating in sort of a weird way.
For sure. No, it is crazy how different things are different, just when I remember medical school, some of our cadavers, we had like 25 or so, and we'd go around and look at different ones, and just people that are the same age, same reason they died, and their organs are all just different and weird. It's kind of crazy. So
yeah. And if you get the chance to do fresh tissue stuff too, is that just the colors are different, the arrangement, like the size of stuff. Like it's crazy to see how different people are one from the other, but yet at the same time similar. Right? It's like, and then you get into all just the wacky pathologies, which I often joke that it's, if most of the time everything goes right, but if something goes wrong, there's a pathology for it, and almost anything can go wrong, from like weird shit like dextrocardia, where your heart's on the up, it's like rotated and flipped on the other side, and all sorts of crazy stuff.
Oh yeah. One of the craziest I saw in residency, we had a 16-year-old kid that came in with appendicitis, but he had total situs inversus, where all of his organs were flipped backwards. And I'd never seen that before. I've never seen it since. But everything was a complete mirror image. So we had to take his appendix out from the left, the patient's right side over to the left side. That's where the appendix was. But everything else was just crazy. And so I think I was like a 4th year resident. And so you have 5 years of residency. And usually by the time you're up there, you do surgeries by yourself. But my attending kicked me to the side. He's like, "You're not doing this. I've never done one of these either. So come on." But yeah, so that was pretty crazy. So for sure.
Yeah. I used to work for a medical device company. And so I'd observe a lot of procedures. I worked in technical service. And so they're putting in a pacemaker. So they put the device in, they have little wires, they run down into the heart. And so they're going in through the vessel. They usually get access, right up at the top part of the rib cage. Mm-hmm. And they put a little wire in, and then they run the leads over it. Yep. And so we're all watching on fluoroscopy, which is just fancy x-ray. And we're looking at the little wire, and we see it go in, and then we see it, because fluoroscopy is just 2D, right? So you're just looking at the scan in lifetime straight down. And we see a wire which appears to go straight into the lung of the patient. and everyone in the room just like stops. And I'm standing behind the anesthesiologist and I'm looking at the monitors, and the monitors are all fine. And for like half a second, a couple seconds, even the main doc's like looking around, and then nothing dropped. And they realized the patient had what they call persistent left main, where the vessel structure actually takes this completely different path somewhere else. And so they were still in the vessel. They hadn't punctured into the lung. It's just this weird anatomy thing that makes it look like you're in the lung because you're looking at just this 2D view, and they verified it and switched the views and stuff. And they're all like, oh, thank God. Oh, that's good. But it was crazy because I'm standing there and I'm going, I'm like started backing away. I'm like, shit's going to hit the fan now. And everyone just stops. And I'm like, oh, the patient didn't crash. This is good. I'm like, what's going on? Yeah. You see all sorts of weird stuff at times.
Oh, for sure. Yeah, absolutely. So
cool. Anything else on that? Any sort of preventative things people should know, or symptoms possibly that they should talk to their doc?
Yeah. So one study I read, basically, increased activity can lower risk of gallstones. So basically, again, it kind of goes with, obesity and diabetes. Metabolic syndrome can cause an increase in gallstone formation just because you're not healthy. Things aren't moving through properly. Usually diet is bad. So again, that's one option. There is one medication on the market. It's called Actigall that supposedly dissolves gallstones, but it doesn't work. I think I prescribed it. No. It takes over a year to even maybe be worked, but everybody I've ever prescribed it for, because they want to be, all natural, and I'm completely on board with that. And I was like, well, I'll give you this medication, but when you're ready, call me. And I've got all of their gallbladders, because they were like, okay, I've taken this for 5 months. It's not doing anything. I'm ready.
Yeah.
So that's one way, or just trying to, decrease your cholesterol intake, doing more of like a Mediterranean style diet. That's kind of been shown to do that. And as far as exercise also, exercising does not prevent gallstones, but usually more of a healthy lifestyle, thus you'll be less likely to make them. And so it just kind of goes hand in hand with everything else.
Cool.
So that's kind of the main thing with that. Yeah. So then there's other there's like some sort of visceral manipulation techniques that can be done that some people really believe in. I've taken a course on it before, and it's kind of different. So like there's a technique called gallbladder flush, which basically you kind of get behind them, you put your hands underneath the rib cage and basically milk the gallbladder. And there's studies shown that people had gallstones before, then they ultrasound them after, and the gallstones are gone. So you can kind of manual manipulation type of thing, but I've not really done much with that, but I know it's out there. So some people looking for like a visceral medicine or a visceral manipulation specialist can go to get different entities done, supposedly breaking up scar tissue, or, making hiatal hernias less painful by massaging the sphincter, the GE junction or whatever. So there's a lot of other alternative medicines out there you can do, but it's not really mainstream medicine. So
do you do any visceral work, since you have kind of an osteopathic background? That's usually bigger in osteopathy. I mean, general.
We learn, like, it's kind of like nutrition. We had one course on it. We only did it once. And so I actually took a full course of it back in August of last year. I went out to Denver and did a 3-day course, and I haven't practiced it much. It's just interesting concept where you can, just basically you palpate and try to see if there's an organ dysfunction. There's like your organs make these little movements that are very subtle, that you try to find that, and you can augment their movements to try to increase disease, or decrease disease symptomatology. And I just haven't done enough of it to know if I buy into it or not. There's a lot of people out there that do it though. And so I feel just like anything else in life, that if a lot of people do it, there must be something to it. But if like one crazy person only does it, then it's like, well, maybe there's nothing to do that. But there's a lot of people that buy into it big time. So
a buddy of mine from Australia came over to the US and did like a whole week with, God, I'm blanking on who's like the godfather of visceral stuff.
Well, there's a guy named Jean-Pierre Burrell, who is
that's who it was.
Burrell Institute. He's the guy that kind of created. He's a French osteopath that kind of
it was a French osteopath, and I don't know if you followed him or one of his underlings around for like a week. It was super expensive. He flew all the way over from Australia to do it, and I asked him at the end, I said, how was it? He goes, it was good. It was very interesting. I said, my interpretation, which is just overly simplistic, is it's no different than any other type of massage. You just have a lot of organs and stuff there that you're working around. Like the principles are the same. If something doesn't feel like it's moving, you're trying to get it to move a little bit better. Obviously, you can't use high pressure. And he's like, yeah, after paying like, I don't know what he paid, like 5 or 10 grand or a lot of money. He's like, that's pretty much it. And you just practice a lot.
That is pretty much it, like, for sure.
Okay. And, like anything, like you get into these niches of people who are like, yes, I rearranged their uterus and they have kids now. You're like, I want to see some proof of that, so you have like the end of that. But I've just found with even just doing hands-on work here in Minnesota that it's super useful, because a lot of people who have like breathing stuff going on, like real simply, right? The diaphragm has to come up and go down, and the viscera, the organs have to move up and down a couple inches.
Yeah.
If that whole area, for lack of a better word, is just stuck, then it just impacts just breathing mechanics.
Yeah.
I remember asking Tom Myers this once. I did a bunch of work with him because before I left for the training, people were just giving me a bunch of shit for doing visceral work. And I asked him that, and he looks at me and he goes, yes, the viscera has to move up and down a couple inches, and just kind of walks away. Like, why are you asking me this? Of course it does.
Right.
So,
there's a lot of things to that, like I do, somebody's in like, there's different ways to increase parasympathetic tone or decrease sympathetic, like a common use after surgery is people have a post-op ileus where, their bowels are asleep from anesthesia or manipulating the intestines or whatever. So you can do some like work on the paraspinal muscles to, increase parasympathetic tone to help them start moving. So there's some data that shows that's pretty helpful. So there's a lot of little things that we can do. The sad thing is osteopaths in general, probably about 10% of people you really use it. And it's just kind of a, like, I don't know, I guess a comfort level. Like I took interest in it, so I feel very comfortable. And I bet 10% of my practice is just manipulation. So I'll get people into my office just to, fix their neck, fix their back, whatever problems they're having. And so I'm a big believer in all of that. So I always feel it's worth trying. It's not going to hurt anything, as long as it's not contraindicated and you're not doing anything crazy. Why not? I mean, it'd be helpful for sure. So
yeah. Cool. And you got time to go over the last one? You okay for time? Or?
Oh yeah, no problem. So the last one we're going to talk about is like gastric ulcers, gastritis in general. So, people can have just upper abdominal pain and vaguely some, typically it's very shortly after eating. It can be certain foods, spicy or acidic foods like citrus, pineapple, things like that. People that take a lot of anti-inflammatory medications. So ibuprofen, Aleve, aspirin. Stress is always a big trigger as well. I kind of always put that at the end of the list. I always look for bad things first. And then if everything else looks fine, it's like, oh, how stressed are you? Oh, I'm a lot of stress. Okay. That's probably why you're having this. A lot of alcohol consumption, smoking. There can also be a bacteria called H. pylori or Helicobacter pylori that can cause gastritis and gastric ulcers. So the only way to really diagnose that is off of endoscopy and biopsying. There is a stool sample you can do that's probably the most accurate of the non-invasive testings for H. pylori, but that the best way is endoscopic, visualization with biopsies. And then if that's positive, you got to do antibiotics.
The discovery of that, like it used to all be stress, and wasn't the main researcher who discovered it, so to speak, didn't he give himself H. pylori and give himself an ulcer and had it imaged?
I think
so sort of as an N of one to prove, because no one else believed him and they told him he was full of shit.
Right. I'm pretty sure that's how that went down. Yeah.
It could be just a rumor, but it makes a cool story.
Oh, for sure. Kind of like the guy that, came up with the idea of washing our hands after surgery, or in between cases that we had little animals that lived on us that were bacteria. Nobody knew that.
They're like, what? You're a crazy man.
Exactly. Yeah, for sure. So, but yeah, so that's the most common thing you see is abdominal pain or whatever. And so to me, I like to know what I'm treating instead of just giving them an like an H2 blocker or a proton pump inhibitor like omeprazole or Prilosec. I like to scope them to see, especially if they've never had one before. Now, if they've had a scope and it's a year ago, usually it's like, okay, let's get you back on your medication. Let's try avoiding certain foods. Let's try, how much caffeine do you drink? How much do you sleep? And try to do lifestyle modifications. But if people, increase their exercise, if they really cope with their stress well, if they can stop smoking and taking alcohol and or increasing their sleep, that's been shown to be helpful. There's a couple studies that I'd read recently that during exercise, so basically your blood, if you're especially like endurance athletes, when you're out running for long periods of time, your blood gets all shunted to your skin and your muscles, and your gut takes a hit just because, well, we're not using it right now. So you just have to take a hit, and you can get like, I want to say the study that I read, if you're exercising around 70% of your VO2 max, you get about a 60 to 70% decrease in your splanchnic blood flow. So you're only getting, 30% of your blood flow to your organs like you normally do. So you hear about, marathon runners getting severe diarrhea during running just because they have no blood flow to it from ischemia. So another thing that I read is that exercise can increase serum oxytocin levels. And if you're given exogenous oxytocin, it has an anti-ulcer effect. So in theory, I think people think that if by exercising more, you're triggering internal or intrinsic oxytocin that may help with anti-ulcer formation. So that's something that's kind of in the literature that's been shown. Another thing is taking turmeric. Turmeric's got a lot of properties that you can use, but it's been shown to be anti-inflammatory, anti-cancer, antioxidant, wound healing. So the curcumin, which is in it, it's about 2 to 5% of the turmeric acid, and so it's got properties like vitamin C and E as far as the antioxidant properties. But there was a study that they did. Basically, they had people, I think it was endurance athletes again, where they had them go out running, and they had the same program, but one arm got turmeric and one didn't. And the ones that got turmeric they showed to be superiorly like gastroprotective. So they had less incidence of ulceration formation just from exercising too much or whatever. So it's one of those things where I feel that it'd be worth looking at as far as taking it if you can handle it or you want to or whatever. So
do you have any preference on the type of turmeric? Because historically the bioavailability is kind of crappy. So there's people who put it in, phytosomes and supposedly lipospheric and putting it with a little bit of oil, or do you have any preference on that?
I personally don't. I haven't really prescribed it a whole lot. I'm still kind of tinkering with this stuff, so I don't have, I kind of just try to research to see what, less ingredients and things. I probably wouldn't get it from Walmart. I would probably spend a little more money for sure. But I don't have a brand or anything that I like endorse or whatever. I'm just kind of like, well, go get it. I'll research. Here's a couple you can give it a try and see what you think and whatever. But I haven't prescribed it a whole lot. So.
Yeah, I know Mariva, that's a trade brand, has some interesting data on it too. I know Thorne has that and some other companies do. So I've used that, and I've used versions that have a little bit of coconut oil with it. And it's anecdotal. I can't say I've noticed a difference per se between people, but that's interesting.
Yeah, for sure. So, and as far as, preventing gastric ulcers, because, if you let them go too long, you can lead to what's called a gastric perforation, or you come in the middle of the night with a hole in your stomach. And, it's kind of, it doesn't happen very often anymore, but it's kind of weird how some pathologies like appendix, they're kind of like, I think it started a day or two ago, but usually with gastric perfs, they're like, it was 8:17. I was watching TV and this happened. It's very specific of when it happens. And to go in and fix it, basically you just go in and you can just oversew the hole and drag a little bit of what's called your omentum, which is the kind of fatty apron that hangs off your colon. We use that as it's like a plug and patch, basically. You just go over, pull the omentum over it, sew that down and kind of plug the hole. And then you put an NG tube down them for a couple of days and make sure there's no leak. And then you can take it out and start feeding them. And so you don't have to do this big gastric resection or, like a gastric bypass type of thing that people get. And it's kind of it's still invasive, but it's less than it used to be years ago. So that's would be a good reason to, prevent this happening, is having a hole in your stomach and you got to go in and have it fixed. So yeah, for sure.
Do you see like PPIs, right? So proton pump inhibitors, as you mentioned, are one of the main drugs used to treat that. I just see more clients now coming in on them. And to me, again, I'm not a physician, but it makes sense to my brain in the short term. But I always have them go back to your doc and ask them, like, are you going to be on this like the rest of your life? Or like, what's your plan to kind of get off it? And a lot of times they're like, oh, I don't know. They just told me to stay on it, which from what I've read, I don't know if that's the best idea.
Yeah, the high dose long-term use has been shown to chronic kidney function decline and everything like that. And it just depends on the person, because typically what I do, if I scope somebody and they've got pretty bad gastritis or ulcers or whatever, I'll put them on my go-to is omeprazole or Prilosec, because it's been around the longest and it's cheap and it works. So I'll put them on that twice a day. And then I also give them sucralfate or carafate, which is a medicine that'll kind of coat the stomach. And so you take them together. And so the thing about that one that sucks is you got to do it 4 times a day to be completely effective. If you take it 3 times a day, it's still pretty good. So the carafate, I'm typically having be on it for a month. So once they're done with a month, and I say, okay, you run out of that medicine, you're done. And then usually what I'll tell them is like, okay, drop from twice a day to once a day on the Prilosec and see how you feel. And within a day or two, if they're not ready, then they're like, oh my God, I felt like crap again. I was like, all right, go back on it for another month, twice a day, and we'll see how it goes. And I always try to get people off of them, but there's just some people that, I don't know, you live in the Midwest also, but in Kansas, most people that come to see me, or they love fast food. They don't want to work.
They may not want to do other changes, right?
Yeah. Yep. So then they're stuck. It was like, well, okay, I guess be on this for the rest of your life if you won't do any other lifestyle changes, because it's really hard to, as you know, to get people to change. And so it's like, all right, well, try to go off it if you can, but then if there's been some disease processes that you have less gastric acid, that you can lead to other, gut problems or whatever. So you get in this big vicious circle that you can't get out of sometimes. So
yeah, because then I've seen, it's like you said, the catch-22 of now they start having digestion issues going on that they didn't have before, but they probably need to be on the med because they've got the thing going on in the stomach. And yeah, that's what makes me nervous about people long term. And I get it. Like, if you're not going to do anything to change your lifestyle, then you're kind of stuck with what you have. But I think sometimes physicians don't explain to them that, hey, here's what's going on. Here's our plan of what we want to do. Oh, and by the way, this involves you changing your lifestyle. And, some people are going to want to do that. Some people won't.
Yeah.
But I think it's probably easier because so many people don't want to do any lifestyle changes. You've got 15 minutes to talk to someone to not give them the potential option either, because that's more work, more interaction. In the back of your head, you're probably going, 90% of people don't do it at all. So I get why there's not always the option of, here's kind of the long-term plan too.
Right. And typically what I always do too is I always, I think, with polypharmacy in America, I always look at medicines. I'm like, well, a couple of these could be causing your problem. You're on, chronic meloxicam for your low back pain, and, taking that twice a day or once a day or whatever can cause ulceration. So I kind of try to find medications to see if we can stop them also that may help. Or if you're taking ibuprofen every 6 hours, it's like, well, let's try not doing that and see if you get better. Right. And so, but a lot of people don't. And I always give them options. I'm like, hey, if you want to do lifestyle changes, I like doing those things. Come back and see me. We'll sit and talk about it. And I bet maybe 1 out of every 100 actually do. Most people just don't want to. And it's so frustrating for me. It's like, help me help you. And I'd love to help you. And I'll block off time just to talk to you. But most people just, I don't want to. I just want to take a pill and be fine and whatever. So,
yeah. If somebody does want to do lifestyle changes, what would be like kind of the top 3 things you would look at for that?
I mean,
from what I've read, it's pretty hard. Like, I have one client, I've got a couple of clients who have had it, and like the literature I've pulled on it for lifestyle stuff, it just seems like I might as well take a shotgun at a target and just kind of start guessing stuff.
Yeah, for sure. And it's, if there's easily modifiable things, which definition of easy, depending on who you are, but like smoking, alcohol,
right.
Acidic foods, stress, like, so all those things, if you can get those in check, I think that would help a lot. And then again, looking at medications or, whatever, but everybody, it's like, well, every time I eat pizza, I feel like crap, but I love pizza. It's like, well, okay,
you have a choice.
Right. So, but most of it comes down to lifestyle modification. Weight loss has been shown to help with reflux disease, and all of that too. So it just, as far as non-lifestyle changes, there's not really a lot that I can work with that. So I can't even really speak on that because a lot of it's on the patient. They're going to do what they're going to do. So sometimes it's really hard to deal with that.
Yeah. Cool.
Yeah.
Awesome. Any other concluding thoughts? And we'll give out people where they can find you.
I mean, just, get your colonoscopy, be healthy, do some sort of exercise that you can change a lot of medical problems. And I feel, diabetes is a complete lifestyle disease. I mean, yes, some people are plagued with genetics, but more often than not, it's just, lack of education on diet and exercise. Just try to be as healthy as you can. If you don't like going to doctors, well, then be a better human for yourself. That way you can avoid seeing people like me, maybe, but that's pretty much it. I'm out here to help people if they want to be helped, and I just, love doing this kind of stuff. So
that's awesome. And I think you also highlighted how much of an effect exercise has. And I know that seems like kind of a statement, but I mean, I went to school to be an exercise physiologist, and every day I continue to be just massively impressed about the effects exercise has on almost everything in the body.
Oh yeah.
And this is an area that is incredibly understudied, right? Because no one's really paying for a lot of these studies.
Right.
So it's an area that we don't have a lot of data. Almost all the data we have so far shows that it's beneficial to literally almost every organ, system, and cell in your body, which just continues to fascinate me.
Oh yeah. I mean, between the fasting for like autophagy and just getting out and walking. Some people, they equate, well, I can't run, a marathon, so why try? It's like, well, just go walk. I mean, I'm all about simple. You don't have to go to the gym. You don't have to get any memberships. Just put on your shoes, go out and walk for 15 minutes and come back in 15 minutes, 3 times a week. Start with that. And then things get easier. Just getting started, as you talk in your different classes and courses that you offer, just get going and do something. It's better than nothing. And, because some people just equate, they got to go, do CrossFit or go do, heavy weightlifting, which I'm a huge proponent for. Resistance training has been shown to be beneficial more than anything else. But if you don't want to do that, get up and walk, or just do, chair squats, go home and stand up out of your chair 10 times holding a can of soup or something. Or it's so easy to do, just nobody wants to take the time to do it. So.
Yeah. And that's the benefit too of if you are untrained and you're listening to this and you're not doing a lot of formal exercise, the benefit you're going to see from like 0 to like 1 day a week is massive, right? Just doing something, you're going to see so much of a benefit. Like if we look at the amount of exercise it takes to slightly lower blood pressure, it's not that much exercise, right? And these are all untrained people. Like you can kind of be an idiot and go to the gym and get better for the first several months, right? So I think that's actually something that my profession has done a very poor job of explaining to people, because it's still, oh, you got to walk, 10,000 steps a day or you're a slug. And people are like, I can't do 10,000. I'm not even doing anything. Right? It's like, if you did 5,000, you would see a huge benefit from the 2,000 you're doing right now. So I think we do a poor job of kind of overselling the high end and underselling just do something and you're going to be better, and just start there, like move where you can and then get a little bit better over time. So that's my plug.
For sure. Oh yeah. And it's hard to get started, but once you get going, you Definitely. Feel better. I know when I haven't exercised for about 2 or 3 days, I'm just irritable and whatever. And it's like, go to the gym, I just got to go out and run or go lift or something. And I feel so much better. And, your cognition is better. You just have all these health benefits that you don't think about, that just do something, and just do something you like. If you hate running, don't run, go ride your bike, go swimming. There is an aerobic exercise you can do that I don't think you hate every single thing. Just find something that you enjoy and then do that, it's not just going out to train for a half marathon or whatever. Just get up and walk, go. Yeah. Whatever,
do recreation, like go do Brazilian jiu-jitsu, do tennis, do something that your brain has to think about. Obviously I'd be biased, go learn to kiteboard, surf, whatever. But get movement, do something you enjoy, get some brain function. That's a easier starting point than even formal exercise for a lot of people. So
absolutely. Yeah.
And where can people find more about you? I know you've got some info. You've got a super cool podcast if people want more of the intersection of fitness and medical stuff.
Yeah. So I started a medical fitness podcast probably about, 3 months ago now. It's called The Morrissey Movement. So you can look at it on all the main podcast players. I'm on Apple, Google, Spotify.
And how do you spell that for people who are bad spellers like me?
Sure. So it's THE and then MORRISSEY and then movement, MOVEMENT. So that's my podcast, and you can just Google it. And I use Captivate for my podcast hosting, so I can take you to that website and you can listen to it off of there, or you can go. I actually put them on YouTube also. Nice. I have a YouTube channel. There's no video. I've just been making audio for now, but probably someday I'll do some video stuff. But it's fairly easy to find. And then the same email address, the Morrissey Movement at gmail.com. I'd be happy to take any, either ideas for topics to talk about. And my target audience is pretty much general population. I don't target to, medical professionals or, fitness, high-end people. I just general public. And I usually pick one thing in medicine and one thing in fitness and try to tie them together. And a lot of my content comes from just questions I've been asked as a physician over the years, like, what's a colonoscopy? What's it like to get your gallbladder out? And so I just go through simple things. I don't use a lot of big medical jargon. I just try to make it simple to understand and simple, short to the point. Sometimes I ramble, but not a whole lot. But yeah, I'd be happy to, talk with anybody or do whatever. I love this stuff. So hit me up. I'd be happy to help. So.
Yeah. And I'll give a plug for the podcast too. I think if someone's listening to this and they're a coach or a trainer, most of the time you don't really get much medical training, but you're going to have clients that will ask you medical questions. And of course, yes, send them back to their doc, of course. But I think if you can provide any background or character, or that's kind of also why having you on this podcast, I think will be helpful, then go listen to your podcast in more kind of plain speak and have more things they can tell their client about colonoscopies or even BMI or other topics.
Right.
I think that's an easy way for them to just get a little bit more educated on those things so that when those questions come up, they can give them a little bit more context. And hopefully then the client is more likely to actually follow up with their own physician and do something then. So
absolutely.
Awesome. Well, thank you so much for all your time today. I really appreciate it. This was super interesting.
No, it's been a blast. I really enjoyed it. Thanks for having me on.
Thank you. Thank you so much for listening to this podcast and this episode with Dr. Chris Morrissey. Really encourage you to check out his podcast. I think it's a very cool intersection of medical and fitness. And I think it'll answer kind of a lot of, just questions people have. Unfortunately, a lot of people I know don't even have a general physician right now. Or if they do, trying to get a hold of him or her is very difficult. So trying to educate yourself as best that you can. Again, not looking to substitute advice from your doctor, but I think everyone should be as educated to their best ability on all matters health and even basic exercise, performance, and nutrition. So that's why I wanted to have Dr. Chris on the show to talk about those 3 common procedures. Because I guarantee they're either going to apply to you or to someone that you love. So feel free to forward this podcast to them. Make sure to check out his stuff. As always, we love any type of review you want to leave. It just takes a couple seconds. Really appreciate it. And subscriptions also help bump up the podcast in all the ratings. This one is brought to you by physiologicflexibility.com. Go there for a complete system on how to increase your ability to recover faster, increase your longevity, and just be much harder to kill. Everything from cold water immersion to sauna to breathing techniques to high-intensity exercise training or HIIT, ketones, glucose, the whole 9 yards. And we go through the big picture to understand the complex concepts of it. Then we break down a lot of the research, and then I show you how to specifically apply it with 5 action items per area. So there's 4 main interventions, each have 2 sides, so that's 8 areas, and there's 5 interventions per area, so that's 40 different action items you can pick from. Again, not expecting you or your clients to do all of them, but it's just giving you options in a system so that you can match the correct action item for where yourself or your clients are at. So go to physiologicflexibility.com. Again, big thanks to Dr. Chris Morrissey for being on the podcast. We will see you all next week.
What's wrong with you?
It's either this show or indigestion. I hope it's indigestion.
Why?
It'll get better in a little while.